multimodality imaging of the reconstructed breast. I would like to welcome Dr. Iman Al-Bakouri. She's Assistant Professor of Radiology in Medical Research Institute, Alexandria University.
Thank you, Chairperson. I'd like to thank Dr. Nuran for the kind invitation, and I'm Dr. Iman Al-Bakouri. I'm going to talk about the multimodality imaging of the reconstructed breast complications. 1 in 8 women in the United States will develop breast cancer. 20 to 40% of these ladies will go for reconstruction of their breast. And currently, the most frequent reconstruction technique are either using the flaps, implant, or a combination of both. Various classifications have been used regarding the complication, regarding their incidence site, and the most important of which is the technique of reconstruction. Let's begin with the reconstruction using autologous tissue flap. In order to diagnose the different complications with the flap, we have to study the anatomy of the reconstructed flap. First, be aware of the common and uncommon complication using the flaps. This is a routine views of the mammography in the CC and MLO. Here we can see the majority of the fat that's present anteriorly and the muscle present posteriorly. In ultrasound, we can pick up the skin, the flapped fat, the flapped muscle, and the chest wall patient muscle. This is a sagittal view of the MRI, and this is the MLO of the mammography, and both shows a line that passes just parallel to the skin underneath, and it's composed actually of the deepithelialized skin of the flapped muscle. And here we can see the muscle posteriorly together with the clips that shows a signal void in MRI. So beginning with the benign complications, the most frequent of which is the seromas and hematomas. And we all know that the seromas is a well-defined elliptical signal void or showing multiple echoes or even septation, and all the seromas assigned as BIRAS 2. Regarding the hematomas, it's completely resembling the seromas, yet with thickened wall and various echogenic content according to the degree of degradation of the blood content. It may be completely echolucent, completely echogenic, or contains a various signal within. Of course, the seromas and hematomas should be assigned as BIRAS 2 to 3 according to the content. Shifting to the mastitis, in which we can see the diffuse skin edema, the edema of the flapped muscle, together with a free-floating fluids that's present within the muscle. Whenever this fluid had been loculated, then this is actually an abscess, and both should be classified as BIRAS 3. Both needs follow-up after proper medical management in case of mastitis and after drainage in case of abscess. The epidermal inclusion cyst actually can be a straightforward scenario, and it can be a complex one because its echo pattern is variable from a simple cyst, hyperechoic cyst, and a complex lesion. And the accurate diagnosis should be used if this lesion is continuous with the skin, shows a punctum, and devoid of vascularity. Here we can see different cases in which the superior one have the skin that enlarged to enclose the lesion here. So this is a classical epidermal inclusion cyst. Again, the lower one both shows a punctum that extends to the skin. So both have punctum and should be classified as epidermal inclusion cyst and BIRAS 2. We shouldn't be confused with these lesions. Yet in this one, we have here a well-defined oval-shaped structure that abuts the skin. Neither punctum is present, nor there is a skin extension to involve this lesion. So this lesion, in case of reconstructed breast, actually consists a dilemma and can be assigned as BIRAS 4, and on biopsy, it shows an epidermal inclusion cyst. Our great biomarker in the breast is the traumatic fat necrosis, and actually this is because the traumatic fat necrosis passes with different pathogenesis stage. First of all, there is herniation of the inflammatory cells into the adipose tissue, lysis of the adipose tissue wall, extravasation of fat, and then the reaction of the body, which can be in the form of fibrosis surrounding the oils to form an oil cyst, or a foreign body reaction to form a foreign body granuloma. The ultrasound actually is an excellent modality for detection of the subacute and acute traumatic fat necrosis, in which we can see the edema that's present within the flap. And again, in subacute stage, this edema may include a subtle, multiple hypoechoic structure representing the various types of degeneration of this fat, and this should be a straightforward diagnosis to virus 2 actually. In case of oil cyst, it may resemble the simple cyst. It's very thin wool, echo-free, and no one can get confused with this oil cyst. It's completely benign. Yet, in the various stages of maturation of fat, before reaching the oil cyst, this can be confusing with a solid lesion. And this actually should be correlated to the mammography, in which we can see the lucences typical for oil cyst formation, and we should not confuse and assign virus 2. In foreign body granulation, actually we have dense fibrosis, and if we are lucky enough, we can see the lucences present in these fibrosis at the center, and hence we can assign it as a traumatic fat necrosis postoperatively. Or we can shift to another modality that shows an excellent resolution of the fat, such as the MRI. Here we can see the reconstructed trem flap with a peripherally located marginally lesion that follow the fat signal in the non-fat SAT and fat SAT sequences. Again, this was actually a tricky case in which there is a heterogeneous suspicious lesion in ultrasound. MRI can pick up the different fat content that follow the fat signal in all sequences. And these lesions should be assigned as virus 2, no one to confuse with. Yet in this scenario, actually, this is a suspicious ultrasound lesion. It's heterogeneous, maybe regular, microlobulated, and it can be assigned as virus 4. And in MRI, we couldn't pick up any macroscopic fat within this lesion, and we have to assign this lesion as virus 4. Here we come the pathologist role to detect the microscopic fat that's present within the lesion. So we can diagnose the fat necrosis precisely if it's located at the periphery of the lesion in the early postoperative period, that's to say in the first 3 months, and it's iso to fat. This is an algorithm for the traumatic fat. If you find a lucent lesion in the mammography, assign virus 2. If you have an isodense hyperdense lesion, assign, do an ultrasound. If you pick up a well-defined anechoic or hyperechoic isoechoic lesion, assign virus 2. These are an oil cyst. If you find a mixed echo pattern hyperechoic lesion present, assign virus 3. This is a subacute traumatic fat necrosis. And if you suspect any solid lesion with a well-defined, ill-defined, irregular, or oval shape, please do a biopsy. And in replacement the biopsy, you can do an MRI, and if you find a fat, assign virus 2, and virus 4 should be reserved for the lesions that you couldn't find any fat within the mass. The second item is the reconstruction with the implants, and actually implant-based reconstruction can be one-staged or multiple stages, two-staged procedure, in which the complication goes most with the expander, which is the first stage. The two-day silicons actually differ. We all notice that the reduction in the incidence of the implant rupture from 20 years ago. Here we can see the double shell of the implant and the cohesive gel present in the implant, yet there is a disadvantage, which is a little drawback, that the implant rupture can go unnoticed without the aid of MRI. So these are the benign complications associated with the implant. We have talked about the infection, hematoma, and seroma. The dehiscence and necrosis, actually, it's a clinical diagnosis. Deflation goes with the saline implant. I don't think we use it here in Egypt. Extrusion is a clinical diagnosis with the inspection of the physician, and let's shift to the residual fibroglandular tissue. Actually, residual fibroglandular tissue can be picked up in the implant reconstructed and the muscle reconstructed breast, and it carries a high risk of recurrence, and it's mainly occur at the nipple areolar complex in case of nipple sparing mastectomy, and in the skin flaps actually in the nipple and skin sparing mastectomy. And this risk actually enlarges and increases if the skin flap exceeds 5 millimeters. Here is a subpectoral implant, and there is a lesion that's present anterior, and this actually was the cause of the indication of the imaging. This lesion follows the fat signal again in all the sequences of MRI. So this is a traumatic fat necrosis, while there are incidentally discovered residual breast tissue present in the inframammary crease, which is actually a difficult case for resection of the breast tissue. Commonly, we see a residual breast tissue in this region. The implant contracture actually is the most common delayed complications, and it's fibrosis or constriction of the fibrous capsule related to the implant. It's predominantly a clinical diagnosis. We all know these 4 stages of the implant contracture, yet on MRI, we have loss of the triangulation of the implant shape, thickening of the capsule, increased the number of the folds, and lately peri-implant calcification. So this is an increase of the AP diameter in correlation to the side-to-side one, and here we can see an impending contracture. Again, this is thickening of the fibrous capsule. Okay, this patient had a 2 breast reconstructed silicon, and here we can see the thin capsule in one breast and the thickened one in the other. Actually, in the literature, there is a cutoff value in some literature that reach up to 1.3. This is the ultrasound features of the contracture, in which we have the double shell and the thin capsule. Here we can see the shell with a thickened capsule, in which there is a condensed fibrous tissue and less mature fibrous tissue present beneath. Implant rupture is one of the main delayed complications of the implant, and MRI actually is an excellent modality for detection of the implant rupture, and it's classified according to the leak of the rupture into intra and extracapsular. In intracapsular, there is a confinement of the silicon within the fibrous capsule. Cautious for our radiologists to depict the intracapsular rupture, because we see it written frequently actually in ultrasound, and it turned out to be just radial fold. So keep caution when evaluating implant in ultrasound. We can see the silicon outside the implant shell and inside within the capsule, yet this may be not a silicon. So again, be cautious when evaluating the silicon in ultrasound. Okay, there are many signs for intracapsular rupture, and the most specific one is the presence of the free shell within the silicon, which is not easy to be found. Actually, other signs include the keyhole sign, nose sign, subcapsular lines, and they are all non-specific. In the extracapsular rupture, we see a herniated silicon outside the capsule, and it's commonly seen in ultrasound as a snowstorm appearance in which there is a dirty posterior shadowing to the silicon. We may see it in the axilla. We may see it even in the contralateral axilla. I have seen it twice. This is again a silicon excitation phase in the MRI, and here we can see the herniated silicon outside the breast. The malignant complication, actually, we will start with the recurrent breast cancer. It's the most frequent complication. Malignant complication reach up to 15%, and it carries multiple factors for being developed. It shows actually a morphology equivocal or correlated to the primary breast cancer, and the site actually, it goes with the skin and subcutaneous primarily. It's the most primarily site, most frequent, and it's easy palpated and inspected by the patient and the physician. However, the second most common site is the presence of the muscular infiltration or muscular recurrence, which is completely hidden site apart from the imaging study. So we talked about the imaging finding in the recurrent breast cancer. That's completely as the primary breast cancer, yet it can demonstrate a very benign behaving lesions, very well-defined oval-shaped masses, Remember the algorithm that we showed. If you're suspecting any well-defined or ill-defined lesion, go for biopsy in reconstructed breast. Here we can see the speculated mass that present deeply in the tram-flapped muscle, and we all assign this lesion as a suspicious finding, of course. Yet this mass is very well defined, and actually it's correlated to an oval, very well defined MRI finding, and yet this was assigned by the radiologist as virus 4. Remember the high incidence of benign looking recurrent lesions in flapped mass. This is a very recent case in which there is a very well-defined lesion juxta to the implant, and the mass actually shows a marginal enhancement, mostly attributed because of she's on hormonal treatment, and she had a restricted diffusion and hypermetabolism in PET study, and we assigned this lesion as virus 4 turned out to be recurrent breast cancer. The lymphoma actually is a scanty cases in which it can be classified either to the effusion or the mass type. Regarding the effusion, it's a gradually progressive developing effusion lately after implantation, okay? It's not a recent effusion, it's a late developing effusion. It's completely non-enhancing, no solid lesion, no papillae present within this effusion. In the mass-forming type, there is a well-defined hypoechoic mass present related to the implant. I only need 1 minute.
Okay.
Okay, so this is a literature review cases in which we can see the well-defined effusion that's related to the superior margin of the implant. The implant is inferior, and this well-defined hypervascular mass, and both was biopsied, and it was lymphoma. Seeing this effusion that's present with no papillae, no solid component, and it had been proved to be a lymphoma as well. So to conclude, no clear guidelines have been established for imaging follow-up of the patient underwent the breast reconstruction, and understanding of the breast reconstruction technique and imaging feature of the reconstructed breast will enable effective interaction between radiologists, plastic and breast surgeons to avoid the delay in the diagnosis of recurrence. Seromas and abscesses are the most common complication, and they are very well diagnosed by ultrasound, while the delayed complications such as rupture and capsular contracture are best addressed by the MRI and physical examination. Fat necrosis may require a multimodality approach. If you find a fat, unless you find a fat, go for pathology. And lastly, recurrent cancer in the reconstructed breast are usually seen in the skin and subcutaneous, and the role of imaging is to establish the disease extent and help facilitate the local excision to prevent the loss of the reconstructed breast. And thank you.
Thank you very much, Professor Iman El Bakouri, for this nice talk. And now the